Welcome to another presentation from Utilization Management University for Physician Education. This presentation is going to be on denials, how best to perform a peer-to-peer. And the best way to get started is to actually look at a denial and find out what is actually a denial. And just to get you to smile a little bit, denial is not a river in Egypt. As physicians, we constantly run into patients who visit that famous river in Egypt, denial, and many times there are some significant negative consequences for doing that. But let's get started with the question, what is a denial? Well, by definition, denial of a claim is the refusal of an insurance company or carrier to honor a request by an individual or his or her provider to pay for healthcare services obtained from a healthcare professional or provider. And quite simply, there are basically two types of denials, two main categories. The first one is that of a functional or process-related denial, and secondly, a technical denial. Let's break that down into further classification with the frequent types of denials. Let's start with late notification, the wrong date, etc., no authorization obtained, clinicals are not received or are insufficient, and lastly, in that category, criteria are not met, and that typically has to do with DRG denials or level of care denials. A lot of the process denials have to do with lack of medical documentation, and as already mentioned, level of care denials, no or minimal MD notes, and lastly, lack of medical necessity, as we are so familiar with those two words. Other types of denials include hard versus soft denial, that is, lost revenue versus potential for recovery revenue, lack of coverage, denials that occur when a payer incorrectly pays a claim, although that doesn't happen very often, clinicals were not received or are insufficient, and again, criteria are not met, but we have to look at that and say, but whose criteria? So to get some understanding of the denials process, let's go over some basic concepts. I think there's one premise that we need to keep in mind right from the get-go, and that is hospitals deserve to get paid, period. Why do doctors get paid and hospitals get denials? And that's typically what happens, as you can see in this diagram. The payer denies the hospitals, but yet they pay the doctors. And why does that occur? It has been said that the payers do not deny the doctors because it may get perceived that they are denying care to the patients. On the other hand, the hospitals are the ones providing the care based on the order of the physician, but yet they are the ones who get denied. So let's go over the process of how does a concurrent denial occur, and why does the process get so cumbersome? Well, initially, a doctor sees a patient, writes notes, and orders. Then, the hospital utilization review team reviews the chart, applies criteria, and calls the information into the payer. The payer UR nurse then takes the data, applies their criteria, and a decision to approve or not, or then goes to refer it to the medical director. Then the payer medical director makes a decision whether to accept it or to deny it, and then the process goes to notify the hospital of the decision. The scales are not adequately balanced because there are some payer advantages. Managed care typically has many full-time medical directors in charge of issuing denials. Hospitals often have inferior processes to combat these managed care UR decisions. Payers often change the rules for their benefit, and we see that all the time. There may be some misaligned incentives between physicians and hospitals, although I don't think we see that as much today. Appeals take time and are non-revenue producing for physicians who do work on peer-to-peers and written appeals. Yet, physicians drive a large segment of the cost and revenue for hospitals, and these dollars need to be aggressively managed. Let's talk about some other aspects of how physician-driven cost and revenue actually occurs. Physician documentation is not optional. Yet, hospitals must follow physician orders for patient care. It's the law. Third-party payers want knowledge and explanations for the dollars they spend. Again, the hospitals get dinged, but not the physicians. Think about an invoice for a car repair. Would you pay a car repair bill without knowing what they actually did and having it well documented? I doubt that you would. But yet, that's what's expected to happen if there's no physician documentation to support what has been ordered and what is being done. In my opinion and my experience, it does sort of come down to a cat and mouse game. Once a denial occurs, utilization review may request the physician to appeal. So the physician calls the medical director, waits on hold or leaves messages, tries to schedule an appointment, and that could take a long time to occur. Then there's an unrealistic window for the call. Many times you see a window of several hours or even a day where the medical director may call at any point in time. Then the payer MD calls when the physician is in the OR with patients or gone for the day, and they do not connect. They repeat this process over and over again. The payer MD closes the case due to not connecting. And that's what leads to the lack of overturns. Let's move on next to a very important area when dealing with appeals and denials, and that is peer-to-peers. Let's start at a very basic level. And what is a peer-to-peer? A peer-to-peer is a physician-level, peer-to-peer review of the medical records and is often used by health plan professionals to determine whether to uphold a denial of coverage for a specific claim. It is said to be a peer-to-peer, and most of the time it is a physician-to-physician, but it may not necessarily always be. It is a physician on the denial side. These reviews are best conducted by a healthcare specialist in the same field as the original medical claim. As we know, this doesn't usually happen. It is not usually by a healthcare specialist of the same field. But be careful. Keep that in mind, and as you are being careful, how often does this occur? To be honest with you, the physician, that is the medical director on the denial side, is not always of the same specialty as the case may involve. But medical directors are trained to review all of these cases much in the same way as a physician advisor. A physician advisor may not always be of the same specialty as the case implies, but they have training that allows them to deal with all specialties and all cases most of the time. It has been said that the best way to get a denial overturned is to start off with a peer-to-peer. Many times a peer-to-peer may not be offered when a denial is issued. But here are some of the factors to consider in the success rate of peer-to-peers. How much effort is actually utilized in order to do this? Getting it scheduled can be a time-consuming event. One can be on hold for a long period of time just to wait to get it scheduled. The other factor comes into play is who performs it. The attending may or may not be the best choice because they have time constraints. They don't have the skills that are sometimes necessary. The ability for negotiation is one of those skills. But the time constraints is physicians are busy. Attending physicians are busy seeing patients, whether it be in the hospital, whether it be in their clinics, whether it be in their office. A utilization review specialist could work, but they still do not think like a physician thinks. Attorneys are many times used for peer-to-peers, but they may lack clinical knowledge. The physician advisor can be the best of both worlds, and it has been said that there is upwards of a greater than 60% overturn rate with a physician advisor. That is not to say that the overturn rate with the attending may not be close to that also. One must keep in mind that there are many facilities, even in today's age, where there is no physician advisor, or the decision to use the attending more often than a physician advisor is a prominent thought. But why is a physician advisor a best alternative? It's not only sufficient to know the clinical information in a case. Ideally, one must have a subject matter expert level of knowledge of the regulations. We will go through some of those regulations subsequently to understand them. But lately, medical directors on the peer-to-peer will not engage in the regulatory side and will defer that to subsequent written appeal. The denial will not be overturned. It is important to remember that a denial is a denial is a denial, no matter who the payer is. The only differentiating factor is the type of denial. But the appeal process is different from commercial to traditional Medicare. And commercial does include the Medicare Advantage programs because they are contract driven. Traditional Medicare is regulatory driven. But let's get the Medicare traditional denials out of the way first. Traditional Medicare denials have been on hold for a while due to the pandemic and waivers. Rumors have it, though, that there will be very aggressive denials by the Medicare contractors, and we are starting to see some of that. It is unclear what they will be going after, but suffice it to say, it should be aggressive and egregious. With traditional Medicare, there is a 5-level of appeal process, which is much different from that on the commercial side. In order to be successful, preparation for a peer-to-peer is a time-consuming event. First of all, you have to research your case, even if you are the attending, because you want to have all of the data present at the time of the peer-to-peer. Very important is to be respectful to the medical director. Remember that as much as you are angry about the denial, they are just doing their job most of the time. Occasionally, you'll have somebody who is very egregious and non-forgiving, non-wavering, and make their denials based on information that you think is totally wrong. And lastly, do not lie or embellish, because once you do that, and if you're caught, you will lose your integrity for any future peer-to-peers that you might have with this medical director. Personally, I have found that at the beginning of the conversation, it's nice to have a talk about whether it be sports, what's going on, anything but the medical aspect first. But once you get started, ask the medical director what information they have and learn why the denial occurred. Many times you will find that they are lacking a lot of the information, and if you may have a denial on a 5-day stay and they only have information for the first 1 or 2 days of the episode of care. So maintain a clinical conversation. Keep the regulatory knowledge in the background. And remember, it's not about you, the physician. It's about the patient and the hospital. And believe it or not, leave your ego at the door and your anger, because that anger will get you nowhere except a uphold of the denial. There are essentially 2 parts to the peer-to-peer conversation. There's the clinical information and there's the regulatory information. So let's start with the clinical side. So on the provider side, it's often said that physician documentation is lacking on the provider side, and that's mostly true, but not always. There are many who believe that a strong CDI program is the solution, and CDI does play a role, but not a solitary role. On the other hand, more importantly, one must have a strong clinical revenue cycle component, and part of that is a strong process in which CDI plays a role. There is the payer side, which one must be very aware of, and it's not all one-sided, not just deficits from the provider. Realize that the payer may not, and many times does not, have all the clinical information or the correct clinical information. Again, as I already stated, there have been 5-day stays that the medical director only had information for days 1 and 2 at best. They are using commercial criteria such as Milliman or Interqual, but sometimes they state that this information is proprietary for their decision making. And realize this, as I already mentioned, that most medical directors are trying to do a good job and can be reasonable, but there are bad apples everywhere. As I mentioned, there are 2 parts to the peer-to-peer, the clinical and the regulatory. Let's now take a look at the regulatory information, and I'm probably going to go through this fairly quickly because you may not necessarily get the chance on a peer-to-peer to use any of this as part of your argument. Or maybe I should call it a professional discussion. Here are the 5 main regulations that are a must-know for the Medicare Advantage organizations. The MAOs don't necessarily follow these, as a matter of fact, hardly often follow these, but it has been stated that as of the beginning of 2024, the Medicare administrative organizations are going to be responsible for following the 2 midnight rule and other federal regulations. But let's go into them. They start off with the Social Security Act, 1852, the 2 midnight rule, which is a federal regulation, CFR 412.3. Then there's 42 CFR 422.101. I know these numbers don't mean anything to you, but it's important to know where these regulations originate from. The Social Security Act, Title 18. And lastly, CFR 409.10. Starting with the Social Security Act, 1852, you can read these at your leisure, although I know you probably don't have much leisure time to be reading federal regulations, but in essence, this Social Security Act does state that Medicare beneficiaries are entitled to Part A and Part B benefits, and it does not break it down into which payers may provide these payments and those that do not have to. Next is the 2 midnight rule, which, as I stated already, is a federal regulations, and in essence it states that the admitting physician expects the patient to require hospital care that crosses 2 midnights. As you may have heard so often, these are hospital services that are provided. And the second paragraph just talks about what that expectation of crossing 2 midnights should be based upon. And as always, documentation is key. CFR 422.101 essentially says that the Medicare Advantage organizations may not be more restrictive than traditional Medicare. They can be more beneficial than traditional Medicare, but they cannot be more restrictive. Therefore, according to this, they must follow the 2 midnight rule. And in summary, at the bottom paragraph, in other words, Medicare Advantage organizations must ensure they are providing all Medicare Part A and Part B benefits without additional restrictions, and that the plan's policy for inpatient stays is clear to enrollees. Bottom line is, they don't follow that. And the last item that we will cover is what are hospital services, because sometimes that seems to be somewhat unclear, and this will help clarify it, but realize that medical necessity still does play a role. It's not that 2 midnights equals inpatient, period, end of discussion. So this is Social Security Act Title 18, and I'm not going to read through all of it, but realize this is just an example or a federal regulation that states what hospital services actually are and the references to where it comes from. Therefore, just to summarize, denials are becoming more frequent and more egregious. Hospitals denied, physicians get paid. That's not a slam on physicians. That's just that it's unfair that hospitals get denied for providing services that they must by law. There are two types of denials, technical denials and process denials, and we went through some of the examples of that. There are two types of appeals. There's the peer-to-peer, which is typically while the patient is in the hospital or concurrent, and they tend to have a 60% overturn rate or even greater in some situations. And then there's the written appeals, which are if a peer-to-peer upholds the denial, then written appeal is next, and that's where the regulatory data can be presented. And in order to do them, you need to keep in mind the peer-to-peer format. And lastly, there are two important parts to the peer-to-peer: the clinical data and the regulatory data. Hopefully this presentation was helpful to you, and I am certainly available for any questions that may arise. Thank you.